Good afternoon. On behalf of the Florida Department of Health in Volusia County, welcome to the Path for Hope Summit 2021. This session is being recorded. My name is Lynn Kennedy, and I will be the facilitator for this session. You've joined the session titled The State of Harm Reduction in Florida. And we're happy to have you here today. All participants or attendees are muted during this session and your cameras are off. You may ask questions in the chat throughout. We'll have a question and answer period at the end. And at the end, you'll also be able to raise your hand. If you move your cursor toward the bottom of the page, you'll see the raise hand symbol. And you can do that and we'll recognize you and unmute you to ask your question if you prefer. We'd like to thank the Path for Hope Summit Planning Committee partners, Advent Health, Community Coalition Alliance, One Voice for Volusia, SMA Healthcare, and the Volusia Recovery Alliance. It's my pleasure to introduce Tim Santamour today. And Tim has worked at a variety of HIV, AIDS, and harm reduction organizations since the early 1980s. In 1991, he co-founded Prevention Point Buffalo, a syringe service program, or SSP, in Western New York. He has also worked for the Lower East Side Needle Exchange Program, Dance Safe, and most recently, Steady Collective in Asheville, North Carolina, and Florida Harm Reduction Collective. Through the years, he's helped develop and implement SSPs, overdose recognition and reversal programs, prevention and education outreach for nightclubbers, ravers, and musical festival attendees. He currently lives in St. Augustine, Florida, and is the executive director of Florida Harm Reduction Collective. Welcome, Tim.
Thank you, Lynn, and good afternoon, everyone. As she said, my name is Tim Santamour. I'm Executive Director of Florida Harm Reduction Collective. And today, what I want to talk about is the state of harm reduction in Florida. Little bit of what I'll cover, if my screen wants to work. There it goes. First off, we'll talk a little about what harm reduction is, and then kind of look at and examine some of the services that harm reduction entails. From there, we'll talk about how agencies, organizations, and communities can collaborate on harm reduction efforts, and then examine the barriers to services that those organizations can address, and then look at some of the positive outcomes of harm reduction over the years. First, a little bit about Florida Harm Reduction Collective. We are kind of a new 501c3 not-for-profit. We just got our status in April. And we have been funded by the Gilead Compass initiative to build a harm reduction network across the state of Florida. Our mission is promoting health and safety for drug users, their family, and communities across the state of Florida. And our vision is a state free of HIV and hepatitis C, drug overdoses, soft tissue infections, a state where drug use, education, prevention, and treatment organizations work together to develop programs that further healthier decision-making for drug users, their families, and communities. A state where law enforcement, recovery, and harm reduction organizations work to end the harms associated with substance use and misuse. So we're kind of both addressing both use and misuse. A lot of times, I think when we talk about drug use, we don't always bring in some of the other more socially acceptable drugs, such as alcohol and tobacco. And harm reduction certainly looks at those substances and how can we minimize or eliminate use and misuse among those, as well as the more kind of already accepted, harmful drugs that are out there. A little bit about what harm reduction is. Harm reduction incorporates a spectrum of strategies that include, I have to change my camera here, I apologize. That includes education, prevention, safer use, managed use, and abstinence. And we do that by meeting and involving people who use drugs where they're at. And that both means not only where they're at in the community or in our communities, whether they're housed or homeless, whether they're incarcerated, whether they're in a treatment facility or a sober home or something like that. It also means where they're at in their use, whether that be chaotic use, maybe it's chronic use, sort of managed, or maybe it's recreational use. Maybe they're what we would term a weekend warrior, someone who goes to a music festival and maybe doesn't normally use a substance, but decided for that weekend for one reason or another to do that. Because harm reduction demands interventions and policies designed that serve people who use drugs, reflect specific individual and community needs. So what we mean by that is we don't come in with an agenda, that we insist fits all communities or all situations. We work with those communities. We work with drug users, families, law enforcement and such within those communities to develop programs, to develop strategies and amplify those strategies so that they can, so that they're effective, so that they're just not wholeheartedly rejected by a community. And because of that, there's no universal definition for harm reduction. There's no universal formula for harm reduction. A lot of times, when I was moving to Florida, folks were saying to me, as somebody who had been involved for 30 years, mostly in New York, which has a very robust harm reduction program. And in fact, the state of New York has an Office of Drug User Health. Folks were kind of like, well, you're going to find things a little bit different in Florida. And the one thing I'll say that I did find in Florida is that there's an awful lot of harm reduction going on. They're in a whole bunch of different communities or a whole bunch of different types of organizations, law enforcement, treatment, recovery, street outreach, sex workers. And what I found was that folks are beginning to build a robust network in Florida. And so that's what we look to do as the Harm Reduction Collective. We look to help that build a stronger and to build stronger relationships between those communities. And so a little bit of history of harm reduction in its past in the United States. So harm reduction has been around since the late 80s. It started mostly in New York and the West Coast. Started with a lot of folks worked in treatment, or folks who were HIV/AIDS activists, saw that the current programs available for drug users weren't working. We were seeing large spikes of HIV among injection drug users in New York and San Francisco. Some estimates were as high as 75–80% of injection drug users were HIV positive. And folks had been, a woman by the name of Edith Springer had been to Europe and looked at harm reduction programs in England and kind of brought those back to the United States and started doing training around what harm reduction was, what strategies we could use that weren't simply abstinence-based or law enforcement prohibition-based. What could we look at that maybe could work at a time when when somebody who was seroconverting to HIV positive was probably not living more than 6 or 12 months after their diagnosis. So we were in kind of a crisis situation, and we realized we needed to do something quickly. So in the early 1990s, a number of syringe access programs opened up across the country. Some of them were legal programs. In New York, around 1992, programs became legal. But a number of them were what we would call underground or unauthorized programs operating in states where syringe access was not legal. In fact, the possession of a syringe itself for the purpose of using an illicit substance was not legal. But programs nonetheless sprouted up, began working with drug users and involving drug users in those programs. And a few national organizations also came about. the North American Syringe Exchange Network, Harm Reduction Coalition, Harm Reduction Alliance, Drug Policy Foundation and Alliance. And these organizations furthered kind of best practices and policy decisions, worked on legislation so that we could pass and open syringe access programs where folks that were running the programs weren't worried about being arrested for doing something. So right about 1994, 1995, for those of us who are old enough, we used to talk about non-hepatitis A, non-hepatitis B hepatitis infections. And in the mid-90s, a researcher in Tacoma, Seattle, Holly Hagan, and another researcher at Yale University, Robert Heimer, really started to look at what became known as hepatitis C. And we started to see spikes of hepatitis C among injection substance users. And, again, rates 80 to 90% of some drug injection circles in New York and in New Haven and Tacoma and Seattle, where folks were hepatitis C positive. The interesting thing about it is we weren't seeing those high rates of HIV in cities like Tacoma or New Haven. So we had to start addressing more than just the syringe, looking at other strategies for disease prevention, such as providing people with cottons or for filtering their drugs, with cookers for preparing their drugs, talking to folks about how easily hepatitis C was transmitted as a bloodborne disease. And so harm reduction services started expanding. And then again, harm reduction services expanded around 1995, 1996, mostly from a program in Chicago Recovery Alliance. A guy by the name of Dan Big was witnessed one of his friends overdose. And when the paramedics came, they used naloxone on him, but Dan had never seen that happen before. And he asked the paramedics what they were doing. And he was told they were using naloxone to reverse the opioid overdose. And Dan, being a long-term treatment specialist and operator of a syringe access program in Chicago, got the idea that we would start doing drug overdose prevention and reversal directly to drug users, going into shooting galleries, going out onto the street and talking to drug users and providing them with naloxone, with syringes to draw and inject naloxone into somebody who had overdosed, as well as providing people linkages to care from emergency rooms, referring them to treatment programs or referring them to a syringe access program if they weren't engaged at the time. Later in the 1990s, there was a rapid expansion of syringe services programs, especially as the attitude changed within the CDC, SAMHSA, and such. And we started to see more and more studies supporting the effectiveness of harm reduction, the effectiveness of syringe access programs in reducing infection rates among drug users, in lowering crime in areas around syringe service programs, or even a safe consumption site such as Insight in Vancouver. They saw precipitous drops in crime around that facility. And so these scientific studies gave politicians the cover, if you will, but also the authority to say, hey, we need to change something. And further, as we move into the 2000s, we're seeing now where syringe service programs and harm reduction being incorporated into all kinds of service in healthcare organizations. The notions of recovery and abstinence and harm reduction and law enforcement and such, they're no longer mutually exclusive. They've all started working together. They've all started to develop relationships and partnerships to further our efforts of disease prevention and getting folks off the streets and into treatment. As I've been talking about, harm reduction is an array of services. And I like to refer to it as, those services from the streets to abstinence. They can be many different things. They can come from many different communities and in many different settings. For example, peer-focused street outreach programs. There are a few very robust street outreach service programs in Florida, one in Duval County, Underground Recovery Jacks. There's one in Central Florida, Orlando. There's Underground Needle Exchange, as well as Flash Exchange, Rebel Recovery in West Palm Beach. IDEA Miami is doing street outreach in Miami. Tampa has IDEA Tampa. They're out in the streets. And then added to that, and kind of like I added the plus signs to the end of these little bullets because things build. Once we may start a street outreach program, then we start to think about mobile and fixed sites and adding those types of services. A van that can provide HIV testing or medical wound care. A fixed site where a participant can come in and get telehealth or case management. There may be showers or laundries in those fixed sites. And then even further linking to medical and recovery community organizations. IDEA Miami being kind of the prime example of that, where it's everything from a peer-focused street outreach program to advocacy for patient care within the hospital. We see recovery community organizations such as First Coast Recovery Advocates in Duval County, linking folks from the streets to services. There was an example of one young woman who was involved in the street outreach program in Duval County. She asked the outreach peer worker, kind of explain that she was moving to Florida and needed help. She was in chaotic use. Her partner was in chaotic use. And the peer outreach worker in Duval was able to refer this woman to IDEA Miami, in that this woman engaged in syringe access services to begin with, but then was able to get health care, get on to medication-assisted treatment, and now considers herself in recovery for the past 9 months, stable, housed, and actually started a job lately. And then the last bullet here is a question mark. For me, as somebody who's come through 30 years of harm reduction in the United States, I don't know what's next for us. There are a lot of questions out there on the table of how we can make the pathway to healthier living for folks who use drugs. How can we make that easier for them? How can we remove those barriers that may be in the way? So who's involved in this? As a lot of folks know, and you're already networking folks, recovery community organizations or individuals in recovery are involved in harm reduction. Behavioral health professionals and organizations, whether you're counseling somebody and not demanding that they be completely abstinent of their substance before you start counseling them, that's harm reduction. And I've seen a lot of that happening in Florida. Law enforcement agencies, parole and probation departments. Duval County has an agreement with Salzbacher, one of the homeless organizations, to divert folks away from kind of a revolving door arrest situation into more stable housing, into mental health services. And that's where law enforcement is involved in harm reduction. Treatment providers, clinics and hospitals, as we've already mentioned, folks meeting with a peer specialist, folks who've overdosed, meeting with a peer specialist in a hospital and getting referred to a treatment program. First responders. We see a number of first responders across the state now handing cards to folks who refuse transport to a hospital after an overdose, handing them information about the syringe access program in their county or about the Narcan distribution program in their county. Drug users, their families, friends, and allies, they're certainly central to this, to harm reduction. And we see a lot of involvement statewide from folks, from families who've lost loved ones to overdoses and such. And then community centers. The center in Orlando is very involved with IDEA Orlando. Churches, schools, education programs. And then what we're seeing more of is an interest from the entertainment and tourism industries. The realization that everyone needs to be involved in this, that if everyone's involved, we can reduce the harms associated with drugs. And kind of, I wanted to break down, a little bit more the areas of expertise that folks on this call may have, depending on where you fit. If you fit into law enforcement, your areas of expertise are in drug courts. Law enforcement assisted diversion, as I spoke about in the previous slide, referring folks who are on the street, instead of arresting them, referring them to services, referring them to treatment. And then some law enforcement agencies in the state are involved in Narcan naloxone leave behind programs. Completely out of the realm of law enforcement 5 years ago, 10 years ago, but now, recognizing there's a need to provide a family member with Narcan or naloxone and leaving a few boxes with them, as opposed to just kind of walking away and washing their hands of it. Law enforcement, I think we hear a lot about fatigue and compassion fatigue among law enforcement officers. And I honestly don't think that that's a true description of it. I think that law enforcement officers are very engaged. They are experiencing trauma, repeatedly showing up and reversing folks who've overdosed. But it's less, to me, fatigue and more a need for us to work across these areas of expertise to provide them with support so that they can provide the people that they're meeting with support. Behavioral health folks, organization, whether you're professional operating independently or whether you're part of one of the organizations, Gateway or Stuart Marchman, providing MAT. At one point, MAT wasn't considered recovery, wasn't considered a pathway to a healthier life. It was considered a kind of a crutch or a pass-through phase of somebody's use. But now we're seeing more and more where medication-assisted treatment is long-term. It involves more than just getting folks out of chaotic use. It may also involve helping somebody work through their drug court mediation case. And so behavioral health folks are working directly with law enforcement to strengthen those ties, to make sure that the person that they're engaged with is successful and actually meets the requirements from drug court and doesn't end up incarcerated. Telehealth has exploded since COVID, and behavioral health folks are certainly involved in that. And folks are accessing telehealth in different places. Some are accessing telehealth services while incarcerated. Others are accessing them when they're in a community organization, whether that be a syringe access program, or it could be a recovery community organization that has a computer in a private room that somebody can go in and sit in front of and talk with their person. Community organizations that have areas of expertise in syringe access or overdose prevention education training. and community assisted diversion, working with law enforcement to divert the person, maybe a problematic person in their community, to a treatment program, to a behavioral health program, instead of calling the police. There are examples of several of these across the country where a bodega owner may call the syringe access program, or may call a behavioral health specialist to come out and engage with somebody in their store who's causing trouble, as opposed to calling the police, and involving mental health providers before we provide before we have law enforcement intervene. So there's a lot of expertise in the state, and there's a lot of collaboration already going on. And this is just an example of, as I've talked about that, referring pre-arrest individuals to low barrier services, notifying service providers of situation in which an arrest isn't necessary. Again, maybe somebody disrupting a store, or on the street corner disrupting, and the officer drives by, recognizes the person and calls up the mental health provider or the syringe access program and says, "Hey, I see your participant here. Looks like there's a little bit of trouble. Maybe you can send somebody out and engage with them." And what we're also seeing is how this communication is working is it's helping to reduce chronic arrests and repeat overdoses. There was the one gentleman that I can think of in Duval County. They had talked about how he had been arrested 19 times within an 18-month period. But since engaging with Salzbacher, hasn't been arrested again. And that certainly reduces the stress on law enforcement officers, the feeling for law enforcement officers that they are not accomplishing anything, because they kept seeing this guy again and again. And it helps relieve that stress, and it's a story of success that can then be repeated again and again. Networking, meetings like this, sessions like this, where we're all coming together, listening to each other, talk about what we're doing out there, how we're working together, or how we're working with our participants, and networking, making sure that we're aware of services that are available. Referring clients, behavioral health specialists are referring clients and families to syringe service and overdose prevention programs. It's a big step to realize that maybe somebody's not yet ready to enter a treatment program, wouldn't be successful at a treatment program, or maybe there's not a slot in the treatment program for them. And to refer that individual to other services, to kind of like have them in a holding pattern so that they can survive to the time that a slot opens. Again and again, I hear stories from families where family members were waiting for a slot to open up, and then they went out into the street, they bought substance and it had ended up having fentanyl in it, and they overdosed. So working to build these networks so that we know when and where to refer folks as they walk in our doors. Collaboration also works by reducing stigma, building capacity, and reducing work risks. And a lot of that work falls on community organizations. Setting up education around prevention services that are available, and support for families and drug users. Community organizations can work with law enforcement, state and county, local health officials to expand services, to challenge the notions of drug users not deserving these services, or to put a face on the overdose crisis, to put a face on substance use and such. Community organizations can also monitor program participants, refer services, account for activities of folks in their program, and stay in communication with local community to kind of address problems as they arise, to respond to those. If somebody, we have a lot of complaints about syringe litter in some parks, or um, um, sorry, I'm blanking on the word, lots, building lots, or something in a city. If folks call the community organization can address that, maybe do a syringe pickup event, or kind of find out who's dropping the litter from their program, and talk to them about it and say, hey, you're supposed to be bringing those back to us. And one way that has worked with the implementation of syringe services program is Miami did a study of a couple of the parks around the syringe exchange program. And from before to after the implementation of a syringe services program, they saw more than a 50% reduction in syringe litter. So it's making communities safer by the community working with the syringe access program to address the problem of syringe litter. But there are still some barriers. A lot of what we talk about in harm reduction is not meeting people where they're at, as I said at the beginning. But I think that the key to this, that a friend said on a call I was on the other day, is but not leaving them there. Providing the ability for any positive change in that individual's life. And that may be as simple as regularly brushing their teeth, or regularly eating, making sure that they've got sterile injection equipment for their next use, so that they don't seroconvert HIV, seroconvert hepatitis C, or get a soft tissue infection. And kind of stabilizing folks so that they can move on to the next step in their healthier decision making. So reducing stigma and assumptions about people who use drugs is essential to this, and the thing that I think about often is that when you're making a statement about a drug user, you're probably talking about somebody in the room or on the call. And if not talking about somebody that's in the room or on the call, you're talking to the parent or loved one of somebody who's a drug user. And to remember that to use sensitivity, to use compassion, and to use person first language when talking about folks and when talking about the services we're providing. Recognizing how race, economic status, gender, sexual orientation have all played a role in exacerbating substance use and misuse. How systemic racism has really been built into the drug war, and how those communities are vastly disproportionately affected by the laws we have in place, but also recognizing how these communities have addressed substance use all along. Just because there wasn't a program in a community doesn't mean that community wasn't figuring out how to feed, clothe, care for the children of people who were using drugs and who needed assistance. It's been going on, for over 100 years, where communities have been addressing substance use without the help of outside organizations, and to not be the organization that walks in and says, hey, we've got the solution for you. Instead, as I started out, being the organization that walks in and sits down and says, what do you have going on here? How can we help? Challenge the assumptions that people have of how harm reduction may not be a legitimate strategy to addressing substance use, with all of the scientific studies, the data that's out there, the first person language in the personal stories. I think of how well somebody like Melissa Salazar from Underground Recovery Jacks speaks about her experience as a substance user, and how she personalizes that and puts it out in front of people. Those are stories that are compelling, and the success of being involved in a harm reduction program and getting to a place where Melissa is today, a professional working for a recovery community organization, advocating for syringe service programs. I think of how big of a success Melissa is, and I'm proud to be able to call her a friend. And the other thing that we can do to reduce stigma assumptions is to let our guards down, to not take what somebody says personally. There are a lot of different narratives out there regarding substance use. And just because your or my experience may be one thing, it doesn't mean that somebody else's experience isn't valid, and they may lead to changes in how you feel about substance users. So I think that's an important thing, is that our personal egos can often get in the way of how we change our viewpoint and how we can move forward and progress. So I want to talk a little bit in kind of closing before we take questions about some of the successes of these programs. In New York, when I started doing syringe access programs there, we saw very high rates of HIV infection among Black Latinx communities, especially disproportionately than white. But over the 20 or so years that the programs were in place, we saw those numbers drop. They're still disproportional based on race, but the numbers are certainly there. The science is there to say that harm reduction works. And I would compare New York with Tacoma, Washington, where there was an early intervention. It was the first syringe access program in the United States, run by Dave Purchase. And their HIV infection rates, as you can see, never, for all communities, never got above 4 or 5%. They were able to keep HIV in check, and therefore use the resources that were available towards other ends, other goals that they had. I've already talked about the 50% reduction in syringe litter in Miami. These are just a couple other studies that have gone on that have been published. Reduction in crime and chronic nuisance arrests around syringe access programs. We've seen reductions in overdose, syringe service programs and law enforcement, reducing overdose incidences across the state of North Carolina. Is where this study mostly focuses on, although Robert Childs does focus on other parts of the country as well. But these are just a few of the outcome studies, and I can share information on this with you if you'd like. Here are a couple more, looking at a bridge to treatment for folks. Up to 5-6 times more likely for somebody entering drug treatment from a syringe services program, 5 to 6 times more likely to be successful at that program, make it through and actually live a healthier life. We're also starting to see some reductions in hospital costs from the prevention of not only HIV and hepatitis C, but bloodborne soft tissue infections such as endocarditis, which can cost us up to $250,000 for valve replacement for somebody with endocarditis. So these are some of the potential outcomes of these collaborations, of this networking and working together. As I started out saying, of breaking down the silos between our areas of expertise to talk and network with each other. And that's what Florida Harm Reduction Collective is kind of here to help folks do. We've already held several technical assistance programs. We look to hold some more in the future. But if you need to connect with us, this is our email. Either myself or Courtney Peters will respond to you on this. We tend to get back within a day or two. You can follow us on Facebook, Florida Harm Reduction Collective, Inc. That's where we announce our technical assistance series. Our next one coming up is a best practices overdose education and prevention programs. So looking at the programs across the state and looking at best practices for those programs. Folks that are doing education in bars or at electronic music events. Halloween is coming up in Florida, and there'll be a dance safe group there. But also working with street outreach programs, and working with hotels and the gentlemen's clubs, to use the euphemism, where we're also seeing a number of overdoses. And just to give our funders a plug, we are supported by a transformative grant from the Compass Initiative at Emory University, which is funded by Gilead Pharmaceuticals. And we're just here to network, to offer our expertise and experiences, and to move harm reduction further forward throughout Florida. So I'm going to stop sharing. Well, I'll leave this up for a second, but I'm going to go and I can take questions, comments. We can have some conversation.
Thank you so much, Tim. We really appreciate this overview of so many collaboratives and networks that are working in Florida. If you would like to ask a question through the chat, please enter it there. If you would like to verbally ask a question, move your cursor toward the bottom of the screen. You'll see the raise hand option. And if you raise your hand, we can unmute you to ask your question. I would like to ask, through all of the different activities that you've seen, how do you see the change in readiness among Florida policymakers for all of these advances?
Well, I think the sort of big thing on that was that 5 years ago, Idea Miami was given the kind of green light to do a pilot program. They opened the syringe access program, and we're working with folks and publishing data. And 2 years early, the state legislature decided to shift from a pilot program authorizing only one syringe access program to the Infectious Disease Elimination Act, allowing any county to open a syringe access program, or any county to open a multiple of syringe access programs. Excuse me. And I think that just kind of goes to the success of harm reduction in working together. And then, from there, those programs, I think there are 5 now. There's Miami-Dade, Broward, Orange, Hillsborough, and Palm Beach counties. And those organizations work closely with treatment providers, law enforcement, in opening the programs and operating the programs. We've seen ordinances to start syringe access programs in Hillsborough, Alachua, Leon. Laura Villafora-Rey spoke earlier today about Duval County's efforts to pass an ordinance. In that ordinance was as much initiated by the community saying that we wanted a syringe access program in Northeast Florida, as a county commissioner who kind of said, I think it's time for this here. I think we've got the data, we've got the information to support syringe access in Duval County. Let's start working on it. Let's make that a reality. And that has seen cooperation from the Jacksonville Sheriff's Office, and other organizations across the county. And I see that happening more and more. We currently work with 14 counties in various stages of opening a syringe exchange, whether they're just starting to look at what is entailed in a program, whether they've kind of got a stakeholders group together that is getting an ordinance passed and talking about actually opening the doors, or whether they're getting ready to open the doors. Broward County opened about 2-3 weeks ago. They were the last ones to open. And so we're seeing cooperation on multiple levels. And I'll say I talk a lot about syringe service programs in Florida because that's kind of the one service that's missing. We have certainly could be better, more funded treatment slots, more funded housing and such, but we have a good framework on which to build and to launch ourselves into a more comprehensive system of services. Syringe service programs, they're the one thing that's lacking, that I think we can look to other parts of the country and say, this is essential for us to have.
Thank you very much. I'll invite you again to participants if you would like to enter questions into the chat or raise your hand. And as we're progressing toward that, I will go ahead and thank Tim Santamour for speaking to us today and sharing his expertise. And I want to let you know that tomorrow we will start again at 10 a.m. with a brief introductory session, which will have announcements and updates for the day. And then you can use your program again tomorrow to follow links to the sessions that you would like to find. There will also be a link to a session survey that will be placed into the chat box here to evaluate the session. And we look forward to having you join us tomorrow, and we hope you had a good afternoon today. Do I have any further questions for Tim? I don't see any hands raised. I see a big thank you in the chat for you, Tim, from Diane.
Thank you, Diane.
So thank you so much this afternoon. We hope to see everyone tomorrow, and I will also an awesome. Don't want to leave before we get that one in there. Pam, thank you so much. She offered awesome to you. So I will go ahead and close this session this afternoon. Thank you again, Tim.
Thank you. Thank you for having me. Everyone have a good afternoon.